Mark and Clif. So we're gonna, kind of our agenda for today, both Mark and Clif are gonna do some introductory remarks, and then I'll just help to moderate some questions, and I think our plan is to try to wrap up so these guys can get to their next thing around 11:30. So with that, I'll turn it over to Mark and let him take it away.
Hey Beth, thanks a lot. And first of all, I want to thank all of you for being here at our convention, covering it in your publications. It adds a lot, and we really appreciate it. And then even more than that, let me thank you for all the work that you have done during the pandemic. You know, the pandemic has been hard on everyone. I've never run a media operation. I don't know what is involved in putting all of it together, but I'm sure it's been challenging, and I'm sure there have been changes and it's been difficult. And I think every step of the way, you guys have been there to cover what's happening, and it has helped us explain to the government the challenges that providers are facing. And you know, I think it's been helpful as we've lobbied those issues. So thank you for doing that. My messaging today is I want to just kind of give you an update on where we're at clinically with COVID, and then where we're at on the business side. So the super good news is that the clinical issues are largely behind us. The nightmare scenario that we faced 2 years ago and even a year ago, you know, have gotten dramatically better. And you know from the data that the number of cases of COVID, although at times still quite large in the general population and even in skilled nursing facilities, the numbers have generally come down. But far more important than that is that the new variants are less fatal. Very few people are going to the hospital, very few people are dying. Providers have gotten really good at taking care of people on the clinical side. And I think sometimes we worry so much about the business side that we lose sight of the fact that that's a significant accomplishment. There are pandemics in world history that have gone on for longer than 2.5 years. Hopefully this is not one of them. It appears that it's not. And so the clinical news, which is the most important thing, is really good. Unfortunately, on the business side, things have probably never been worse. If you just think back to a year ago when we had our first time of having annual meetings since the pandemic started, many of us, including myself, were hopeful that by the time we got to the end of 2022 or early into 2023 that we'd have a complete recovery on the business side. It's very clear now that that's not the case. And it's really a combination of two challenges that have both, you know, one has not gotten much better since last year, and one has actually gotten worse. So the one that has not gotten much better is census. We are unfortunately in both assisted living and in skilled nursing not back to our pre-pandemic census levels. We started out the pandemic at about 80%. We dropped down to 67.5%. We've recovered about half of that. We still have 5 or 6% to go. But unfortunately, in the course of the last year, we've only gained between 2 and 3% on the census side. It has not come back at the rate that we had hoped that it would. If you just extrapolate that same level of recovery out to the future, it means that we could be, you know, well into the end of 2023 or maybe even into 2024 before census recovers for the entire sector. And that's a reality that we have to deal with. It is something that the providers have to factor into the decisions that they make, but it is making it very, very hard for the sector. The second challenge, which I think is actually worse than last year, is the labor situation. That's really two problems with labor. The first is we just cannot get our workers back. The number of people that are actually working in the general economy are the same right now. The general workforce has recovered. If you look at the number of people that were working before the pandemic and you compare it to the number of people that are working now, the workforce is back. Unfortunately, it's not back in long-term care. We still have over 200,000 less workers in our facilities on the skilled nursing side. We have over 40,000 less workers on the assisted living side, and it's very concerning. It creates all kinds of issues. Most important, it makes it very difficult on the care side because it's so important to have adequate staffing as we take care of our residents. It also has impacts on the business side because our providers generally are having to close wings, stop admissions, not letting people in because they just don't have the workers to take care of them. The second challenge with the labor force is cost. When we can find workers, we're having to pay them a heck of a lot more than we were before. The data indicates that when you look at the cost for CNAs, LPNs, and RNs, the total cost has gone up about 22%. The overall inflation rate in skilled nursing buildings and assisted living buildings has been about 9%. Now, we're not concerned about the fact that wage rates have gone up. That's actually a good thing. We want people in buildings to make a livable wage, and we want it to be a career and not just a stepping stone to something else. But it only works out if it's reimbursed, and in many of the states, the reimbursement just hasn't been there. So the question is, what do we do about, it's great news on the clinical side, but it's really challenging news on the business side, and we need help. We need help from both the federal and the state governments. On the funding side at the federal level, the most important thing that CMS can do right now is to issue a Medicaid adequacy rule. CMS has talked about really putting some teeth into its authority to require states to pay an adequate amount of Medicaid to all healthcare providers, not just skilled nursing facilities, but all healthcare providers. In far too many states right now, the reimbursement for Medicaid is dramatically less than the actual cost of taking care of people in nursing facilities. And CMS has the power, and we urge them to enforce it. Secondly, we're going to need some help from the states. A number of states have stepped up during the pandemic, and they've used some of the hundreds of billions of dollars that they've received from the federal government to help providers, but unfortunately some have not. As the crisis on the business side continues, it's important for every state to utilize those federal funds to step up and to help. On the labor side, the workforce side, there are a couple of things that the federal government can do. First and most important, it needs to not make things worse. It's the Hippocratic oath, do no harm. And unfortunately, the current focus of the administration will make things worse. The proposed unfunded minimum staffing requirement will make an already horrible labor situation worse. And that's true for a couple of reasons. The workers are not out there. We are already short 200,000 workers in skilled nursing facilities. The data show that in order to meet a 4.1 staffing requirement, we'd have to come up with 100,000 workers on top of that. Simply getting back to our pre-pandemic workforce will take incredible innovation, effort, and thought. To think that somehow we could get that to that level and an extra 100,000 workers is simply not realistic. The other problem with the proposal is that right now the funding isn't there for it. Medicaid funding is already inadequate for the staffing levels that currently exist. And to suddenly impose a 4.1 requirement and think that the workers will somehow magically appear and somehow be paid and paid for is simply unrealistic. Instead, what the federal government needs to do is it needs to shift to areas that actually can help, and there are two. And that's areas of innovation and immigration. On the innovation side, we have proposed the Care for Our Seniors Act, where we have encouraged Congress, the administration, to offer incentives for people to get into long-term care and to stay into long-term care, offer the same kind of tax credits, scholarship programs, et cetera, for nurses that we've offered in other settings. And we think that if we can encourage people to get into long-term care, we can expand the pool of workers. On the immigration side, it's low-hanging fruit. There are hundreds of thousands of people, maybe millions across the world that want to come into the United States and do the work that we're having a hard time finding other workers for. There are many of them that could work in skilled nursing facilities and assisted living buildings, and it just doesn't make sense that we're not taking advantage of the fact that people want to come here and do this work. I realize that comprehensive immigration reform will be difficult and challenging and is politically divisive, but it is such a layup for the country, for the economy, and for the people that live in our buildings that we're hopeful that after the elections, when some of the politics can calm down, perhaps people can come together either in a lame duck session or early next year and do what is the obvious thing that needs to be done, which is to let the people that want to come here and do these jobs come here and do them. So with that, I'm going to turn it over to Clif, and Clif is going to give us more of a DC perspective.
Great, thanks, Mark, and thank you all for being here with us this morning. Just to expand a little bit on what Mark was sharing, obviously, the Congress is kind of ground to somewhat of a halt when it comes to business, just in light of the midterm elections looming. And we're obviously watching those elections and outcomes very closely. It's a toss-up. I could prognosticate about what I think and who wins. And at the end of the day, I'll probably be wrong. So I hesitate to do it, but I think, ultimately, there will definitely be an outcome. and we will obviously adjust our sales accordingly. I think a few things in light of what Mark has said is that, clearly the COVID pandemic has created a situation for us, at least while it's been dire on many fronts. It's actually positioned us in the center of a lot of policy discussion. So I always, try to look at the lemonade out of the lemon and make something from that. And I think that's definitely the case. Folks understand what we've been dealing with. They've been exposed to it in great detail in their individual districts. And regardless of whether you're Republican or whether you're Democrat, you've been impacted by this pandemic. So for us, it's really amplifying that message, right? So we want to continue to amplify the message, all the things that Mark talked about. We want to. Mark will tell you, I've been traveling the country the last few weeks and basically sharing and helping our members articulate some of the challenges that they've been facing, just so we ensure that these members of Congress that are coming into Congress or that are already here fully appreciate and understand the local impact of the pandemic on their districts. Workforce is clearly a big issue for us, and as we get into the end of the year, it looks like it's not going to be a lot happening from the perspective of legislation except for potentially an end of the year package. What will be included in that, we do not know. There's lots of talk about the National Defense Reauthorization Act, that potentially being a vehicle for other priorities as well. We've got another continuing resolution that will happen in the middle of December that will need to be renewed again as a potential additional vehicle. And obviously for us, we've got a couple of key priorities, particularly around workforce. Mark spoke to the big kahuna, if you will, from the perspective of policy, and that's immigration policy. Not optimistic at all that there's going to be any significant movement on immigration in the near term. But we're doing everything we can to try to impact the workforce issues and challenges bit by bit and bite by bite, and that's the best way to describe it. And a couple of them have to do with workforce supply issues. And for us, the first is the Cna Training Expansion, which is on Senate 4381, HR 8805, but essentially what it does is it allows our nursing centers to be able to expand nursing assistant training themselves to hopefully expand and build on the workforce. I feel good that we got a good possibility of hopefully getting that included if something actually does open up as it relates to a vehicle. And then the temporary nursing assistant issue, which I'm really passionate about. You probably know I'm a former operator. I don't think there's any more important thing that we can do is to have the people that we need to take care of the residents that we serve. If we don't have the people that we need, we can't serve our residents well. Ultimately, that impedes census, which is what Mark spoke to earlier. A lot of the driver behind our census challenges is not necessarily demand, but it's just frankly getting workers, and we're not gonna take patients that we can't take care of. So ultimately, we gotta get staff so that we can take care of more people. And that's the biggest challenge. And the temporary nursing assistant waiver was an essential tool that our facilities used around the country. And I'm really excited about the fact that CMS did make a decision to allow states and facilities to apply for waivers. As you know, many states were approved. So we have good news on that front, that the temporary nursing assistant program will continue for a good number of states that applied. Obviously, facilities have applied too. We're waiting to hear about that, but it's not a complete and full solution. So our bill is still very important, and it's important for a lot of reasons, because not only those states that applied and got approved, that's great, but within those states and within the states that didn't necessarily apply or get approved, their facilities that still have a challenge, right? So we've got to get this bill where that blanket waiver is reinstituted, and ultimately giving our facilities a chance to continue to employ these vital workers. I like to say over and over again, these folks are the kind of people that we absolutely want working in our sector. They ran to the fire. We had a crisis, we had a challenge. It was deadly, frankly, if you think about it. There wasn't enough PPE, and these folks came anyway. And to me, it's miraculous and remarkable, and they're the kind of people that we want working for us long term, and anybody that's in that program deserves a chance to ultimately get certified, ultimately build a career, and develop a career ladder in our profession. So we're going to be working really hard to push that particular waiver across the finish line, and frankly, it's in the best interest of not only providers, but more importantly, our patients to have these caregivers at the bedside. For the end of the year, that's really what we're focused on. Workforce. Again, I call it, sort of nibbling at the edges. It's not the big tectonic move that we'd love to see with something like immigration, but we think that if we can get these two pieces of legislation across the finish line, we can hopefully make a dent in some of that gap that Mark spoke about as it relates to our workforce earlier. So that's what we're doing, and again, open up if anybody has any questions. Be more than happy to answer them.
When would you look for to know, or when will we know if you get something across the finish line? What's going to be your indicator timing wise? Or
Yeah, I think as we get closer to the middle of December, we'll know what train's moving out of Union Station. We don't know necessarily yet which one is. Continuing resolution clearly will. There's a preference by Congress to keep that clean. That's the term they use, and I have a lot of stuff attached to it. Just extend the government, be done with it. There have been precedent where that hasn't happened, and they have attached priorities to it, so that's a possibility. But we do have this end of the year priority stuff that they got to wrap up a few items of business, and it's clear that I think everybody wants to try to get something done before the new Congress begins. So I hope that we can actually get this inserted, and we got some supporters that are very, very interested in helping us do that. But mid-December is the time frame.
Okay.
Yeah.
Can you talk a little bit more about the specific priorities as it relates to the state Medicaid bumps and trying to get some of those permanent or extending them beyond where they're at currently? How many, I'm not sure if you know off the top of your head how many states you guys are kind of targeting, but is it more than half the country? Is it less than half the country? Kind of where are we at with that?
Yeah, I'd be happy to answer that. So traditionally, the role of AHCA has been to work on the Medicare rate in DC. We have 50 state affiliates, and their job has been to work on the Medicaid rate. About 5 to 7 years ago, the board decided to shift strategy in consultation with our affiliates so that we are now actively involved in state Medicaid efforts from the AHCA level. We only do that when the states ask for our involvement, but we have a group of really good people that work with our state execs and our state associations when we're asked to go in and get involved with the states. So one of the things that's been fun about the evolution of AHCA and my time there is to suddenly get involved in all of these state initiatives. The reality is that more can be done at the state level than can be done at the federal level, because Medicaid is really what it's all about. It's our primary payer. It's what most of our members and all the providers rely upon. And so AHCA's focus on state Medicaid issues has been really, I think, a smart decision by our board. It's also been fun, and it's been successful. We've been able to go into a number of states and work with our state associations and see some significant increases. What we hope that all 50 states do is to rebase their rates, to take a look at the actual current cost of taking care of people in a Medicaid setting, not relying upon numbers that in some cases are 10 years old, where they just attach an inflation number to it that doesn't really connect with what's happening in facilities. So we would hope that every state would actively consider rebasing its rates. We would hope that every state would take the add-ons that they provided during the public health emergency and include them into the rate. Right now, there are still, I believe the number is 12 states that have Medicaid add-ons that are tied to the public health emergency. So when the public health emergency ends, those add-ons go away. We're encouraging all of those states to include them. And then finally, just our general lobbying point that we make in DC, which is that we encourage every state to pay as close to cost as possible so that providers don't lose money on Medicaid and have to figure out other ways to keep their doors open. But we're actively in discussions with all 50 of our affiliates. We're actively involved in probably 20, 25 states that AHCA has a presence in, hoping to move the Medicaid numbers.
Does that work you described also include assisted living providers who might
get
does.
waiver funding.
It does. So increasing, I mean, I think another really exciting development has been the ability of assisted living providers to participate in the Medicaid program through home and community-based services. It's opened up that product to a whole swath of the population that previously has not had enough money to qualify. You know, in its infancy, assisted living was primarily for upper middle class and wealthy people just because of the cost of private pay. But these innovative operators that have figured out how they can make it work in an HCBS setting, you know, are really inspiring to us and the work that they're doing and providing the product to a lot of people. So we have been supporting that work in DC by working with CMS on exactly what the HCBS waiver should look like. But we're also getting involved in some specific state efforts. The first state that we got involved in that was a specific assisted living effort was Idaho, where the association there asked us to get involved in an effort where they were attempting to increase the rate, and we got involved, and I believe that work was successful in Idaho. But anywhere that our members ask us to go, we'll take a good look at participating.
So I know, I understand the problems with the minimum staffing requirement, but the pressure of that has obviously been driven by concerns about quality. How do we get to quality without the minimum standards?
I think there's been a dramatic improvement in quality in nursing homes over the last 50 or so years, and particularly in the 10 or 15 years before the pandemic. I don't think the sector gets credit for that. The advocates have been really, really good at portraying skilled nursing as a business that people are only in to make money. The care isn't there, and you know, typically they've been successful in doing two things. One is they've gotten a very broad definition of abuse and neglect. So abuse and neglect in a survey setting includes a whole bunch of things that I don't think the public would consider to be abuse and neglect. They've also lumped abuse and neglect together, so that they've taken things that are neglect, and by saying they're abuse and neglect, all of a sudden it makes this apparent that because the definition is so broad that, you know, essentially every facility in the country is a bad facility. It's been a real disservice, I think, to the public, and it's really hidden the good work that's being done. It's so much better to make policy based on real data as opposed to anecdotes. And if you look at the real data, the quality measures that were measured by CMS, almost all the quality measures we've seen material improvement in the last 15 years. Doesn't mean that there won't be isolated cases of poor care or poor outcomes or poor results, and we don't want any of those to happen, and anything that we can do to get to perfection we want to try to do, but it's very, very hard to get to perfection. One of the things I spent some time yesterday afternoon, I don't know why I got onto this, but I decided I was going to look and see what the current thought was about unnecessary deaths in hospitals. Now, if you just Google this up, after this, you know, take 5 minutes after this and Google up the topic unnecessary deaths in hospitals. There is a debate out there whether every year there are 44,000 or 88,000 unnecessary deaths in hospitals. There's a contrarian out there that said, oh, no, it's not that number, it's actually only 22,000. And the 22,000 estimate is considered to be phenomenal, you know, and not credible. But let's just assume that it's 22,000. Can you imagine if we had 1,000 unnecessary deaths in skilled nursing facilities? We don't have that, but because there is such a microscope on us, because 80% of the CMS funding on the regulatory side is spent on nursing facilities, 80%. All the other healthcare providers, we have, you know, all these people come into our buildings, they watch and they watch and they watch, and finally we have a little slip up and it gets called abuse and neglect because the definition is so broad. And then there are bad individual incidents, and it paints a picture that it's just not accurate. I just encourage folks to look at the data, and the data shows material improvements, and you know, we're doing everything that we can to help our members along that quality journey. There's no question that the pandemic slowed those efforts down, because all of a sudden, you know, instead of being able to worry about rehospitalizations and all of the other things that we were focused on, we just had to try to keep our residents alive. But we're now at a point where, you know, I think we can transition back to our quality efforts, our quality programs, and get back along the improvement that we've seen. But the portrayal of the sector as money grubbing and greedy and horrible providers is incredibly inaccurate and unfair. It's actually cruel to the folks that work in these buildings and have continued to work in them throughout the pandemic. And they've heroically fought to keep these people alive for 2.5 years, and they have to read these headlines about how terrible the sector is, and it has an impact on them.
Yeah, I would just add to that. I think that, be clear, we'd love to have more staff.
Yeah.
We would love to have, and our Care for Our Seniors Act is emphasizes that point. I think, so we're not anti more staff. The reality is we have to have the funding to pay more staff, and more importantly, we have to have the supply of staff to hire in the first place. So we kind of have to get the priorities and policies in order, but more staff's not a bad thing. We support that. But at the end of the day, we have to be realistic about what the requirements are. Putting a requirement out there in an environment where you're down 200,000 folks is just lunacy. It's tough.
I think the other thing is you need to look at data for the policy solutions. And so what the data indicate is that the smartest expenditure of funds is on RN hours. When you look at the quality outcomes and the quality measures, there's a difference between buildings that have a lot of RN coverage and buildings that don't. There is less of a correlation between just having lots and lots of staff. The strongest indicator is RN coverage. So what we did with our Care for Our Seniors Act, long before the Biden administration proposed this minimum staffing, is we said, let's take the limited resources that we have and really pile it into the RN category. Figure out a way to get a bunch of additional RNs, get additional RN hours in buildings. That is a policy that could actually work. It'll take time to develop the additional nurses out there, but it is a policy that could actually occur, and we think that would move the needle more than simply saying, oh, you gotta have 100,000 extra workers that aren't out there.
And do you think the rate adjustments for pay need to be adjusted more at the CNA level than the nursing level, or both, or do you have thoughts on it the same?
Well, look, the market itself has driven wages
Absolutely.
dramatically. So when you think about it, the market itself has addressed significantly many of the wage disparity issues. And I've always said, as an operator a long time, for nursing assistants and staff, I'm glad about it. Look, these folks have worked, particularly nursing assistants and nurses as well. They've been our heroes, and the market's now kind of recognizing their value, right? So the real issue now for us is to get, more or less the reimbursement caught up with that jump that we've seen, and the inflation that we've seen in the wage rates. But you're talking, in some cases 30% compared to pre-pandemic levels. So we're definitely spending a lot more money on staff, and gladly so at this point. And obviously, we'd love to have more staff as well to pay those much more healthy rates too. But again, we just have to get a supply of staff available to hire. That's the key issue.
Mark, how willing would you be, not willing, but how ready might you be to recognize that there's a kind of a leaky bucket syndrome? People are looking for migration toward home health, and you're saying, census isn't regrowing, that it might not get there. That there's a new model out there that you can't chase the old model or whatever. Is that something long range? People might have to come to terms with?
I don't think so. There are states in the past that have worked hard to try to move people out of long-term care and into a home setting. And the reality of a home setting is it's a lot harder than people realize. There are a significant number of people that just need 24-hour care. They need somebody around in case something happens and they're not able to take care of themselves. And there just aren't enough people that I think can be moved from the long-term care setting into the at-home setting that is going to impact the industry. And this has been a challenge or a discussion point for the last 20 or 30 years. And then the reality of home health care is often not as rosy as the picture or the thought of it. Home health has workforce issues too, but the difference is if your home health care worker doesn't show up, there aren't other people in the building to take care of you. All of a sudden you're there by yourself. And so home health is really important, and I'm glad it's out there, and there are people that should be at home that don't need a long-term care setting, but I don't think it's a panacea for people that need 24-hour care or access to 24-hour care. And I think that with the demographics, there will be enough of them that in my view, the census will come back. We'll find out. I mean, we can make these prognostications,
And I
but in
see
2 or
what
3
you're
years,
saying
we'll
from
know.
the patient point of view, but from the business model, so in other words, if you can't get the workers back, maybe you're at a static level, and that may sound a little silly, but is there maybe a rejiggering of the model and where people are gonna go 31 later?
I think that we're gonna continue to see the slow but steady recovery that we've seen for the last year. And the momentum is going up, and as I talk to providers, they're all telling me that they're seeing more people come into the buildings. The numbers are moving a little bit slower, but I think it will occur.
Thank
Yeah,
you.
keep in mind,
I'm sorry, go ahead.
I'm sorry, just keep in mind too, that, you know, obviously a lot of folks migrated to agencies
Yeah.
during the pandemic, and, that's not a permanent, career decision. You do that for a while, and then you're anxious to get back and be a part of a team, to work in a facility, to be part of a family. We're starting to see some of that migration back to facilities as this begins to settle down. So I think that some of the folks that left us, did the work, are now reconsidering that decision, and starting to think about coming back and working more long-term in a career back in our buildings, which I think will help ultimately raise the watermark on census as well.
We've only got time for about one more question. Yeah.
So I know that one of NCAL's priorities is to try to keep regulation of assisted living at the state level. With a lot of assisted living providers receiving funds from the Provider Relief Fund, and CMS recently saying it's considering including assisted living or senior living in general providers in the National Provider Directory, and things like that. Are you concerned about regulation kind of moving and gaining in the federal level?
We're always watching it, for sure. Obviously, we can, Mark can speak as well, but I mean, for us, we're strong proponents of ensuring that, I'm just a big believer that decisions are best made closest to where the action is. And in the assisted living world, obviously, states have regulatory constructs set up, to manage their situations in individual states. There's a lot of talk and discussion, and obviously, some folks that are proponents of regulation of assisted living, but again, the majority of assisted living is privately funded, and I think that as long as that's the case, we'll likely continue to not have federal regulation, but it's something that we're watching very, very closely, and obviously trying to do our best to make sure that that regulation remains robust, but remains at the state level.
Yeah, I agree with Cliff. We continue to have a top priority that it not be regulated at the federal level. I think everything that we've seen happen to skilled nursing explains why that's the case. The overregulation, in my opinion, has not made skilled nursing better. I think it's made it worse. And so we've made it a top priority, and I think we'll be successful with it, but we'll only be successful if we stay vigilant on it, and we will continue to do that as long as our board tells us to, and they tell us it's a top priority.
Thanks, everybody, for your time today. Mark and Cliff, thanks for.
Thanks, Ron. Thank you.